Good afternoon, everyone. I'm Steve Love, President, CEO, Dallas-Fort Worth Hospital Council. We want to thank you for participating in this webinar today. It's another educational webinar, and it's hosted in coordination with Outset Medical, who is an associate member here at the DFW Hospital Council. Today's topic is reducing the cost and the complexities associated with dialysis. This is a great topic. Is dialysis one of the largest, most expensive areas within healthcare? Today's panel discussion will be focused on looking and creating change, looking at the widespread adoption of a new technology, and delivering on a promise of improving the experience for patients and striving to lower cost related for healthcare providers. We're delighted that we've got two excellent speakers today. One is Krysta Myers, who's the Division Director of Dialysis at Medical City Healthcare here in the Metroplex. And we have Laura Romike, who's located in San Antonio, and she's a Senior Vice President of Sales with Outset Medical. We have a tremendous turnout today. We're really looking forward to this presentation. But before we begin, a couple of housekeeping matters. A presentation will be made and then questions will be answered. And we would like to ask for any of your questions, please put them in the chat box or the Q&A box, and we'll make sure and monitor that and make every effort that our speakers have the opportunity to answer those questions. So again, thank you for participating today. Thank you for supporting this webinar. And with that, ladies and gentlemen, I give you Laura Romike. Laura, thank you for being here.
Thank you, Stephen. Thank you for inviting me to participate in this webcast today. I would also like to introduce from Outset Medical, Anna Howard. Anna is our National Clinical Director, and she'll be assisting us during the Q&A session. So Chris, that may be someone else that we may need to unmute. So first, I would like to walk us through a brief overview focused on the cost and complexity of dialysis and the opportunity to create your own dialysis program. Then most of our time will be focused on Krysta Myers from HCA and her experience with insourcing and standing up a dialysis service line. After that, as Chris mentioned, we'll host a Q&A. So let's get started with a few questions. These are designed to stimulate our thinking about the existing dialysis care in your organization. First question, what is the patient experience of your dialysis patients today? Next, are you experiencing increasing lengths of stay due to discharge challenges? Are patients showing up in your ED looking for dialysis support? And finally, have you seen an increase in your readmission rates with your dialysis patients? In working with health systems across the country, we see some really consistent pain points across the kidney care continuum that many of you are experiencing. First is high cost contracts for outsourced dialysis services that continue to increase. Chris, I just received a chat that someone is not able to hear us. Is that widespread or is that just the one individual?
I would think that's the one individual.
Okay. I just wanted to make sure before I continued. So again, high cost contract for outsourced dialysis services that continue to increase. Hospitals are being abandoned with short notice, which puts your hospital and your patients at risk. We've seen examples from 2 days to 30 days notice, with the most extreme case being a hospital that was told on Friday that the dialysis team would not be coming back on Monday. Over the last 12 months, we have seen over 70 health systems being given notice by their outsourced dialysis provider. We also know you're struggling with access issues with discharging to post-acute care facilities because their dialysis beds are full too, or there are no chronic community chairs. This results in extended lengths of stay challenges that are driving up significant costs for hospitals. In addition to length of stay, this current model results in the loss of control and the continuity of care for your patients. And at the first sign of challenges, we know that large dialysis providers have no skin in the game, and they send them back through your ED, driving up your readmission rates and your cost. We also know that existing dialysis equipment requires specially trained staff with staffing issues. It makes it very difficult. And of course, you're vulnerable. You're vulnerable to low patient satisfaction and retention. And finally, we ask, why refer patients to for-profit dialysis organizations when your hospital could capitalize on this outpatient revenue with double-digit gross profit? So now let's look at, why do these challenges exist and why do they continue to grow? Dialysis is one of the largest, most expensive, and least changed sectors in all of healthcare, with over 135,000 new ESRD patients diagnosed annually in the United States, resulting in over 90 million treatments, provided at an annual cost to our healthcare system of over $73 billion. The ESRD population today is over 800,000, and it's growing by 30% over the next 10 years due to increases in comorbidities such as diabetes, hypertension, obesity. So we have this growing patient population being underserved by an already struggling model. The result is hospitals lose money. In the current model, if you are a hospital provider, this is what you can expect. Of those 135,000 new ESRD patients, 60% of them are crashing into your ED, having never seen a nephrologist. This results in extended length of stay, and on average, you're losing between $5,000 and $25,000 per inpatient stay. Patients are eventually discharged to the chronic dialysis center. However, we know that 34% of those patients will return to your hospital within the first 30 days, costing you even more. Nationally, we're spending over $30 billion on in-center treatments annually. And even with all of these struggles, 87% of dialysis patients continue to be stuck in these clinics for chronic dialysis. This means only 13% of patients are going home. 10%, which receive PD, and we know that's a temporary solution. Only 3% are treated with home hemodialysis. We believe this is due to complexities with outdated technology and a lack of patient education and support that HHD is a treatment option for them. So what could the future look like? The future looks like a kidney care service line that empowers you to manage the continuity of care for your dialysis patients from your ED all the way into the home. The major difference in this model is a transitional outpatient program, and here are the benefits. Your CKD, ESRD, and uninsured patients that show up in your ED for dialysis treatment because the clinic chairs just aren't available are directed right to this outpatient program. It enables you to avoid that readmission. Your AKI patients, of course, are admitted to the hospital, but then you're struggling to discharge them because there are no community chairs that are available. Those patients can also be redirected to this outpatient program. Also, patients that are treated in this program, they can be trained to self-manage and they can dialyze at home while waiting for their transplant. You're also going to have patients that you identify that just are not candidates for home hemodialysis. But again, they can be moved into this transitional outpatient program until a chair opens up. The other benefit to this is when your patients experience a challenge, instead of them coming back through your ED, they can come through, again, this transitional outpatient program and avoid yet another readmission. So for you in standing up, right, a transitional outpatient program, you can really impact the quality of care for your patients. We know that staff satisfaction and experience and even retention is improved. You can really scale your operational efficiencies. And of course, like we've talked about, decrease your length of stay and reduce your readmission rates. What we've done at Outset is we've delivered a first of its kind technology. It's called Tableau. And Tableau replaces multiple machines, and it also replaces your water treatment room with a single device. Tableau can be used anywhere. We only require an electrical outlet and tap water. And Tableau can be used anytime with water purification and dialysate on board and on demand. And finally, Tableau can be used by anyone with over 70 sensors, data analytics, and a touchscreen interface. Make Tableau easy to learn and easy to use. And the result for you is you have one device that can be used from the ICU to home. Outset, powered by Tableau, we're making an impact. We're making an impact for hospitals of all types, whether you're a large academic medical center or you're a smaller community hospital. We have demonstrated significant cost savings and also improved staff efficiency, all while achieving equivalent or better clinical outcomes to prior machines. You'll see on the left that in a recent study, Cleveland Clinic was able to reduce their dialysis cost in the ICU from 5.4 million annually to 2.4. And I'm excited to share that in a few minutes, we will hear from Krysta Myers, and she's going to be sharing the financial, the operational, and the clinical impact that she has experienced. And the last slide for me is I wanted to summarize that, developing and implementing your own kidney care service line with Outset will enable you to consolidate to one device across the continuum. And this is going to support your scalability of education, training, staffing, and other efficiencies. And as I mentioned before, we also expect it to improve your staff experience, retention, and maybe even recruitment. You can also achieve significant cost savings in the acute care setting. Most of our customers see a return on investment of less than 1 year. We also talked about the ability to build an outpatient service line, enabling you to stand up a new revenue stream with significant revenue opportunity. And then finally, we want to empower you. We want to empower you with control over the continuum of care for your dialysis patients, enhance the quality of care, and also the patient experience from the health system all the way to home. So now let's transition over to Krysta. Krysta, we thought we'd start with a question for you. What cost savings have you realized and the benefits of using Tableau in an acute setting with your in-source program?
Absolutely. Thank you, Laura.
You're welcome.
Ultimately, I help to oversee a float pool for Medical City Healthcare, and we provide dialysis services for 7 hospitals currently. We do utilize Tableau and have seen many benefits when it comes to cost savings and analyzing our realized cost savings 1 year post insourcing. We are achieving around 25% savings for labor and supplies. And we have ability to increase those savings with initiatives that we are continuing to put in place. One of those initiatives is increased SLED utilization with Tableau in our ICU settings. And looking into this, there's ability to increase the overall savings to a minimum of 40% with increased SLED utilization versus CRRT. And one other opportunity and initiative we are driving as well is a Tableau biomed program, where we will have in-house biomed availability to troubleshoot complications should they arise with the machine. And we also see enormous cost savings projected with that as well. Overall, Tableau is very compact and easy to use, and it's very user friendly. So that's enabled us to have increased productivity, efficiency. It's easy to train our staff on a shorter timeline. So we're seeing numerous benefits just with that in place. The step-by-step instructions on the touchscreen interface is technology that we've needed in dialysis for some time, and it's enabling us the opportunity to cross-train nurses into dialysis from other departments, as well as giving our ICU teams the confidence to move forward with Tableau for SLED. Laura, I think you might be muted.
Can you hear me, Krysta?
Yes.
Okay. I was jotting down a couple questions as you were talking. Maybe another one would be, what are the biggest differences between an in-source and an outsourced program for those who haven't experienced both?
Great question. Ultimately, with outsourced programs, of course, you're contracted with a vendor. There tends to be exorbitant fees for treatment, but in addition to that treatment fee, we also have numerous other fees associated with treatment duration and treatments that the patient may need during dialysis, such as blood transfusions. One other downside to having an outsourced program is lack of overall program oversight. We don't always have consistent review of our outcomes in dialysis. Our staff that are working with the vendor are contracted. So there's not a lot of ongoing education and alignment with hospital policy and procedure. So that can lead to an increased risk for patient safety issues, adverse events, potentially harm, and ultimately a lower level of quality outcome for our dialysis patients. Moving to an in-source program, of course, we have in-house staff that are committed not only to set productivity goals, but also quality outcomes and metrics that are defined. And we have additional oversight and involvement from multiple stakeholders as now we are owning that program. And so it really does lead to increased quality, but also improved overall financial outcomes for the department as well.
Krysta, thank you. One of the things that it came up recently, I was meeting with a group of chief nurse officers and chief medical officers, and one of the things they mentioned is, how does this help us from, a survey perspective? And I am sure you had experience there since you've implemented Tableau. Can you just talk us through anything you saw different when you went through that survey?
Yes, absolutely. For those that have years of experience in dialysis, I'm sure you're very familiar with several manual written logs. And anytime we have manual logs, we have a risk for non-compliance. We have a risk for human error. And Tableau really does help to improve that risk associated. Ultimately, the ability for the machine to Wi-Fi connect and transmit treatment reports, service reports, disinfect reports, that gives you a huge insight into how the program is operating, and also ability to pull that data quickly without the worry that potentially something will be missing. So that is a main driver that really helps with overall compliance and excellent survey outcomes. One other opportunity, of course, is just having that additional program oversight and involvement with an in-source program, and audits to see how the staff are operating and ensuring that they're in compliance with policies and procedures, and also that we have policies and procedures for dialysis. That really helps to improve our overall outcomes. But when you see those standardized practices with an in-source program, then ultimately it leads to an excellent survey outcome as well. Dialysis is always a priority focus for Joint Commission and other surveyors. So to have that ease of mind that we have automated reports to pull with Tableau, and that we have a program with multiple stakeholders that are very committed to its outcome, it really does help us to achieve surveys without findings ultimately, which we're all looking to achieve.
Exactly. That's what I was thinking. It's what we're all looking to do. Thank you. That was a very, very helpful answer. You mentioned staff satisfaction and productivity, and I believe that you've also seen some differences around even all the way to recruitment. Could you talk a little bit about that?
Yes. So ultimately, with the user-friendly machine that is Tableau, we have additional opportunity to train just out of sight of when you're looking to recruit for dialysis. Typically you would look for someone that has that experience already up front. This machine does give you ability to cross-train your inpatient nurses. So increased ability with that to recruit and retain permanent staffing, and even have a model where you have shared staffing between departments. So leads to increased ability to avoid having any contract staff in place. And of course, with our ICU teams, that user-friendly capability does assist with training them in a quicker timeline and helping them to feel very confident with utilizing Tableau for SLED too.
Absolutely.
I will say, just as a touching on productivity, Tableau is also very quick to set up and tear down, and in relation to some of our older technology that we have in dialysis. So that does help us to achieve from start to finish a shorter duration overall in treatment time with using Tableau.
Krysta, thank you. Let's stay on your staff for just a bit. Talk us through what was your experience in hiring, recruitment. You know, one of the most common objections that we hear when we're working with health systems is there's just no way I'm going to be able to hire the staff. So if you could talk us through your experience, that would be wonderful.
Yeah, ultimately with hiring and recruiting staff, of course, it's important to talk through the technology that you have for dialysis, and also the structure of the program. The machine is great, but it's only one component. It's very important to build a structure that will bring the team to you, essentially. And ultimately having physician champions that are invested in helping to create a solid structure, whether it be your orders for dialysis, your supplies for dialysis, things of that nature are very important to help recruit and retain permanent staffing. In addition to that, essentially defining super users for your program. When you're first looking at insourcing, it's very important to bring in some subject matter experts that can then help to train others and help to build that team, essentially, and investing in education upfront. It's very important, of course, to ensure that they're receiving all the training that they need. I think it's great to have Outset support with that. The fact that Outset does offer a tablet coordinator course for super users helps to continue to provide advanced training that will enable them to work through any troubleshooting issues that might be happening with a new program. Anytime you are making change, it's not always easy. So having Outset support with that is very critical to continue to make care improvement and ultimately retain your team once you have hired them. And then continuing to look at initiatives as well, because there's always an opportunity for improvement. So working through those issues that you do find, and then looking for an initiative that will help to resolve it. Just really helps to keep your team together and happy and satisfied.
Absolutely. Thank you. Thank you for sharing that. Could you talk to us a little bit more about Outset and the support that you received from Outset Medical? You mentioned the training piece. Was there other support you received from Outset?
Absolutely. I haven't ever encountered a company that is so involved. And so I'm very grateful for all the support that Outset has provided. With insourcing a program, Outset is there from day one, providing project management tools, assisting with project management calls, and really being there from the beginning to go live and continuing on. You have, when you contract with Outset Medical, you really do have a partner that is also invested in your continuous care improvement. And so it really aligns with HCA Healthcare's mission and ultimately the goal with insourcing. Outset is there to support with on-site training. They are there to support go live and ensure that it goes smoothly. And then they're there from a clinical support standpoint moving forward. There's a dedicated clinical specialist to reach out to with questions or issues that might arise. There's a dedicated service engineer for any machine breakdown. So you really do have well-rounded support with Outset.
Krysta, thank you. You know, I was always told not to ask a question you did not know the answer to, and I did not know your answer. So thank you so much for sharing that. I really appreciate it.
Oh, you're welcome.
Thank you. Thank you very much. So I thought it would be a good time to turn it over for some Q&A. And so, Chris, if you could help us facilitate that, that would be wonderful.
Yeah, and Laura, what we'll do is people are putting their questions in either chat or Q&A. If you don't mind, I was going to ask a question of Krysta first. Thanks, both of y'all done an excellent job. And Krysta, I was just curious, as you move from outsource more to insource, as far as the payers, whether it be Medicare, United, Blue Cross, was that pretty seamless, or did they come back and have questions related to in-source billing versus what it had been previously?
Overall, I would say it is pretty seamless moving to an in-source program. One opportunity and lesson learned that I will bring up with that is ultimately ensuring that the charge list is fully built for that, and that everybody understands it as well. I will say that I provide ongoing education with my team on how to enter charges appropriately based on patient condition and admission status. And I think that's really important to help prevent lack of reimbursement on the back end.
And kind of, I had a question just kind of as a follow-up. I think Laura did a great job of covering this, but helping with regulatory reviews and survey readiness. Since you've had this kind of insourced, Have you been through a Joint Commission survey, and were the Joint Commission, were they pretty pleased with the in-service, or are you still waiting? And full disclosure, Dr. Perlman, who used to be the Chief Medical Officer for HCA, now runs the Joint Commission. So he's a great guy.
Yes, I've been through several Joint Commission surveys, and I'm happy to say that they have gone well overall from the perspective of the Tableau machine. I've heard several comments from surveyors that they're impressed with safety features that the machine has, that it really does keep the patient's safety in mind. For example, we're all human. Someone may miss to do a disinfection the previous evening. Tableau will tell you the next morning, I'm sorry, you're going to have to do this before you move forward with patient care. So safety is top of mind with Tableau, and that's something that our surveyors love to see. And ultimately, those automated reports just make a world of difference with our surveys. We're able to produce the data that needs to be reviewed quickly. And that's always a huge plus for our surveyors. And so ultimately, it's led to really great outcomes.
Great. And we do have a question that's just come through the Q&A. It sounds like, Krysta, you've had a great experience. What have been the challenges that you've experienced with this new Tableau insourcing approach? And were there any unexpected, challenges during the conversion?
Yes, there's always challenges with any type of change, and I will not say that this has been without challenge. Ultimately, some lessons learned with insourcing is who you involve with your project management to bring your in-source program to go live to be successful. I have found in projects where we have our trifecta, our CMO, our CNO, our COO or CFO involved, and we dedicate a nephrologist champion to be present and involved with creation of the program. We build a very detailed supply list of what we will need for dialysis. We have IT involved, we have education involved, really bringing departments together to ensure that we're covering all components. That's where things go smoothly and everybody is satisfied, and also being able to transition Tableau in at times is very helpful too, just to come across any of those bumps that may happen with a go live, and then build upon it to the point where you do feel really confident with Tableau running 100% and being insourced 100% as well. One other challenge that we have encountered is moving from outsource to insource. You do lose that technical support in a way where you have support from Outset for machine breakdowns that may happen, but it's important to think about having your own technical support at the hospital as well for your program, such as a Tableau Biomed. That really does increase staff satisfaction and retention because your nurses are able to focus more on patient care and less on filter changes for the machine and cleaning lines and things of that nature that are more technical. So I would say that's a huge learning opportunity and one to ensure is included in the program when insourcing. And I'm really happy that Outset is offering a biomed training and certification program for that, for those that are interested.
We have another question that's just been submitted. How are you addressing chlorine reports?
Chlorine documentation is separate from those automated Tableau reports. So that is something that we are documenting separately on a log. I will say that one other initiative with HCA Healthcare is moving towards a digital machine log internally with ability to document some of those machine safety checks. As it's not evidence-based to include it in our patient documentation, essentially having a separate electronic log where we're entering chlorine checks, pH checks, conductivity, things of that nature that would also be automated for us.
You know, Laura and Krysta, I don't see any other pending questions. People, if you have any questions, please put it in the chat or Q&A. And Laura, I didn't know if you had any other questions you wanted to ask Krysta.
I think, Krysta, overall, if you were talking to a healthcare organization and they were just considering standing up their own program, what would be the advice that you would give them right now?
Well, I may be repeating myself a bit, but I think it's very important to assess your needs as far as what you'll be covering dialysis-wise on an in-source program. And then from there, of course, how Tableau can benefit you with that. I think it's very important to look at utilizing Tableau both with hemodialysis, but also with SLED to really realize full cost savings. And then, of course, include those other services that the outsourced vendor may be providing, such as peritoneal dialysis, maybe even apheresis, and analyze volumes to ensure that you know not just how many staff you will need, but the size of space that you'll need for dialysis to be as efficient as possible. And of course, space is always a commodity, but one great thing with Tableau is it is small and compact, and it provides you a little bit more space to work with. So considering the unit that will cover that volume with the goal to move the majority of your hemodialysis to the unit. So you're at a 2-to-1 ratio versus your 1-to-1 at bedside. You'll have increased cost savings that way. And ultimately, anytime you're venturing into an in-source program, like I said before, it's very important you have involvement of multiple stakeholders and consistent follow-up throughout the project to go live and beyond, so that you are achieving both the financial improvement, but clinical outcomes where we want them to be.
You know, while you were speaking, we had a couple of more questions. Do you have a model that you suggest for training shared staff? That's question one. And question two, a model for addressing float pool criteria response times.
Okay. So a model for float pool criteria, I guess I would need a little bit more detail on that. Ultimately, when we're talking about response times for orders that come in, we're looking at what we have in our particular program is we have a consistent company chat that we use for our group, where we're looking at anticipated volumes for the next day, and we're staffing based on that. We're watching actual volumes the day of to help determine where our staff need to be. And then in our after hours period, when those emergent orders come in, our policy and goal is to be there at the hospital within an hour to address those urgent order needs. I think it is very important to create a guideline when it comes to that. And so when you're looking at insourcing, things like that should go into your policies and protocols.
A couple of more questions have come in. What is the average cost per treatment with a Tableau machine?
One great thing with the Tableau machine is your supply cost does greatly decrease. You're looking at average around $55 per treatment for overall supply costs with Tableau. And in comparison with your outsourced program, you are paying in excess on average of $100 an hour for the outsourced staff that are providing that service. So you are really cutting your costs quite a bit, moving over to in-source program in general. But in comparing the machine itself with others, you're also seeing cost savings overall. Some of the other machines that you have an option for with dialysis are nowhere near $50, and especially if you use bag dialysate, you're looking well over $200 per treatment.
The other question that came in, as an inpatient hospital-based unit, each time a patient comes into the ER for dialysis, would you send them to the TCU, or would you have to admit them to your unit and discharge them when completed?
So I will say HCA Healthcare does not currently have a TCU, at least in the division that I work. I think that it's definitely an opportunity for improvement overall to look at having that as part of the model. Ultimately, to Laura's point, when a patient presents to the ED, it would be optimal to be able to route them to the TCU with the goal to not have to readmit them. Now, every patient condition is different, and there's definite possibility that they will need to be admitted for other reasons outside of just dialysis. But in that situation where we do have a patient coming in and they've missed treatment, and that's the only reason they're there for the most part, the TCU would be optimal to help prevent that readmission.
Thank you, Krysta. Laura and Krysta, I do not see any pending questions. Both of you have just done an excellent job of presenting. So I thought I would turn it back over to you, Laura, to see if you had any closing comments or if Krysta had any closing comments.
Yes, happy to. I was going to see if Anna wanted to come off of mute. I do think there was one question in there that maybe we did not grab around cannulation. Anna, did you see that question?
I did, Laura, and just to weigh in on that, there's many different models that we've seen utilized for cross-functional teams to learn about cannulation, but Outset does offer a course as well that we can send someone on site to provide that type of hands-on training, work through some criteria and competency, and so the local site then can build those skills internally. Many times we see, for example, a number of cannulations be required after an individual receives training, just to build the core competencies of those team members. And so there's a lot that we can provide on our end as far as the additional, didactic and hands-on training. And then the bedside, skill set is developed over time for cannulation. And then the other component I wanted to weigh in on is the total chlorine testing and some of the functionality that we've integrated to control human factors on Tableau. Number one, when you set up a treatment, the Tableau will prompt you to do a test prior to connecting to the patient for total chlorine. And then you also have the capability to set reminders. So if your treatment time is extended over 4 hours, you can get a 4-hour reminder, or every 8-hour reminder, whatever your policy states for total chlorine testing, just to prevent those, potential misses on, frequency of testing per policy.
Anna, thank you.
And I'll
Pleasure.
just add to that, if okay. Ultimately, when you are insourcing your program, having your super users that are experienced in dialysis really helps to build that ongoing training confidence for the rest of your team. I would never recommend let's go ahead and cross-train everybody into a new program, because you do need those super users to help train on certain things like cannulation and have that continued exposure to start feeling confident with it. So ultimately, having those super for users in place really does go a long way. One other thought is to have skills labs for dialysis when you are having your staff meetings, and to go over those skills and hands-on practice, because when you have everyone together, that's where you do see variation with practice and can work together to standardize and help prevent complications down the line.
While you were talking, we had one other question come in. Did units using cross-trained staff have to adjust their ratios?
So cross-trained staff, essentially with HCA Healthcare, we utilize a shared staffing model. So ultimately, when someone that is cross-trained with dialysis comes to work in dialysis, those hours fall to dialysis separately. So with care ratios, essentially it would be the same care ratios in dialysis as it would be for anybody else. But that person does have to be fully trained and independent and verified competencies before they are moving to independent care with those ratios.
Laura, I don't have any other questions pending.
Okay, anything else from Krysta or Anna before we wrap up?
Whoops, something just came in. Hang
Okay.
on. Let me take a quick look. Does the machine mix dialysate? How long will it take for the dialysate to be ready?
So great question. Ultimately, in our program, we use the acid and bicarb jugs. And so the machine does mix dialysate based on what's programmed using that acid and bicarb jug. From setup, from start to ready to connect the patient, usually takes an average of 15 minutes. So you're looking at within that time period, your machine is mixing that dialysate and doing all of its safety checks. And then ultimately you're running that chlorine check pre-treatment before you get ready to connect your patient. So I guess that would be your overall time, is maybe about 15 minutes for mixing that.
Thanks, Krysta.
Krysta, I just wanted to add on to that as well, in the flexibility for dialysate on demand, should the prescription change. So if we're running, for example, prolonged treatment and going, 6 or 12 hours, and there's a need to change that dialysate concentration, it's a simple change button. Instead of having to tear down bags, you simply change your acid bath and change the prescription on the Tableau, and then you're back up and running in moments. And so that's one of the flexibilities that we've seen as well in prescribing on Tableau.
Yes, and I'll just add there's several other wonderful features that Tableau has. Ability to automatically switch between HD to UF only mode is a huge win for us. Essentially programming that ahead of time, and the machine will switch on its own versus having to program separately. Automatic saline flushes. This is a compliance issue I've seen over and over again, where we have saline flushes ordered on a specific time frame throughout dialysis. But when we're having to give that manually, now we have the risk for human error and missing one of those time frames. Tableau has the ability to automatically provide those saline flushes as programmed pre-treatment. So those are just a few of the additional features that are really great with Tableau and enhanced technology that we definitely need for dialysis.
So Laura, I think that is the question. I don't see any other pending ones, but these have all been excellent questions. And I thank all the participants for taking time to ask very good, informed questions. So Laura, I'll turn it back to you again.
Well, thank you so much, Stephen, and thank you for having us. We really appreciate it. And just a huge shout out to Krysta Myers for sharing her experience with us today. Thank you all very much.
Thanks, and that concludes this webinar. We thank everyone involved, and we hope you all have a happy afternoon. Thank you.
Thank
Thank
you.
you.
Thank you.
Bye.